things were very, very nicely elaborated, and definitely it was taken up by all the participants, and especially I'm thankful to Jawad Farooq and the panelists who basically really contributed a lot. So the before proceeding it, because we are basically conducting on the in the perspective of this day, which is basically Hypertension Day, and this time the idea was actually how accurately one is able to measure the blood pressure, because we can only do better or we can harm a person if we are not able to take the blood pressure nicely, take the blood pressure accurately. So I think that is the best theme of this year, and keeping in view, and now we are heading towards a topic which is basically hypertension and diabetic patients with nephropathy. So once we are going towards this topic, I must say that these two things are just, head upon each other. They are heading towards each other. One is the diabetes mellitus, the other is hypertension. And once these two things, they are consolidated together, they are the enemies, and ultimately the battlefield is the human being. And basically the target organs are affected to such an extent that they have got their own endpoint in the form of ESRD, that is end-stage renal disease. Along with that, multiple associated involvement of target organs of the body, which are very vital, like heart, like patient may have got stroke and peripheral arterial diseases, eyes, and everything. And I would say, as people claim that diabetes mellitus is nothing, but it is the disease of the blood vessel. So wherever the blood reaches, the disease is there. Wherever there is complication, either it is in the form of microvascular complication or macrovascular complication, the ultimately affect are the target areas of the body. So before we are heading towards the this complicated, this dilemma of diabetes mellitus in the form of hypertension and nephropathy, I just want to clear to the participants that previously it was called as NIDDM and IDDM. It means that it was basically clear that it was insulin dependent diabetes mellitus and non-insulin, but now it is type 1 and type 2. And there are certain other situations which are type, basically LADA, body and secondary diabetes mellitus and gestational diabetes mellitus. These are different situations. So today we will only consider type 1 and type 2 and its consequences and sequelae, which basically involve the kidneys and ultimately affects the whole body. When we talk about the diabetic nephropathy, we basically talk about a sort of syndrome in which there is, number one, that patient has got this persistent albumin urea, which is more than 300 milligram per 24 hours, or it could be either 200 microgram per minute per square feet of the body. So that is another way of explanation. And provided this is taken at two occasions, which are basically 3 to 6 months apart. This is one component. So before we basically talk about the other two, this is extraordinarily an accurate parameter, which is one thing. And number two is that patient has got decrease in the level of GFR with the passage of time. This is part of diabetic nephropathy. That is a syndrome. And third one is that patient basically starts rising of blood pressure. So these three components, they constitute the diabetic nephropathy. One is actually the persistent albumin urea. The other one is decreased in the GFR level, and third one is the raised blood pressure. Now this syndrome was really categorized basically in 1936. Although people were sensitized in the late 18th century that there are certain things in diabetics which ultimately involve the kidneys, and kidneys are responsible for high blood pressure. And these were the lesions first diagnosed by the Keimer, Steele, and another person was the Wilson. These two people, they ultimately found out what is nowadays seen in the microscopy, that there are nodular lesions in the form of glomerulosclerosis, and these are called as Keimer, Steele, lesions. And this is part of the staging of different categories of this nephropathy. Now, coming towards the epidemiology, it has been seen that diabetic nephropathy, in case of, for example, type 1 diabetes mellitus, it usually takes almost 20 years. But later on, it rises with the passage of time. And it is said that patients who are suffering from type 1 diabetes mellitus, they usually don't have got lesions before the 5 years of the onset of diabetes mellitus. And then it starts, but ultimately reaching towards a sort of syndrome at the after the 20 years of complicated diabetes mellitus. But contrary to that, if we go towards the type 2 diabetes mellitus, then we will see that some of the people, they may be diagnosed as suffering from the complication of diabetes mellitus at the time once they are diagnosed. And about 5% of the population, they may have got the diagnosis of nephropathy at the moment once they are coming towards the clinics, and the biochemical status is found that they are known, they are basically diabetics as well. They may have got this raised HbA1c, and they basically fall in the categories of diabetes mellitus. So almost 5% of the people, they are diagnosed very early. But later on, their process actually enhances, and it is speeds up as compared to the type 1 diabetes mellitus, and usually in the range of 10 to 20 years, ultimately 20% of the population, they may be affected, but later on, the things that are basically speeds up. Now coming towards, I will bring your attention towards this graphical representation of the natural history of this diabetic nephropathy. For example, it is onset coming towards the 0 point, and then we see that it goes on ranging from one stage to another stage. There are basically different stages. Now all these stages are categorized. First of all, it is hyperinfiltration stage, and then hyperfiltration stage. It goes towards the next step, which we call the silent stage, and then incipient stage, then macroalbumin urea, and then is the azotemia. These are 5 stages. Now, if you see into the chronology, you will find out that the things are very slow to onset, but once they are established, then the things are speeds up to the extent that ultimately azotemia and end-stage renal disease, it strikes with the passage of time. And whatsoever the intervention we can offer to these patients, it is the earlier detection. If we are able to find out the onset of nephropathy at its outset, then definitely we can offer this certain changes, certain interventions. That's why we call it as primary intervention. But once things are established, then it is the secondary prevention, and once the complications, then we ultimately call what's called as tertiary this prevention. Roughly we say, because these are more mathematical, and we cannot simply say that they actually synchronizes with each other, but roughly it is seen that if a patient has got 1 creatinine, we consider that the GFR is 100. And if the creatinine is 2, we call it that it is almost half of the GFR is lost. That is 50 milliliters. And then coming towards the 3 creatinine, in which we consider that it is almost 1/4 remaining portion that is working, that is 25 milliliter. And at 4 creatinine, we could assume that it is 12.5 milliliter, and at 5 creatinine 6.125, and at 6 it is 3.06125. So these are various categories, and these are quite alarming, that just looking at the report, once we see that patient has got this 5 creatinine, you just consider what drastic changes has occurred inside the kidney, and the GFR is remarkably reduced. That is almost 6.125%, we will say, because we started with 100 and then we are left with 6.125. So it's really a great dilemma. So it means that once the kidney dysfunction is quite obvious in a report, then we must try to assume that the GFR has tremendously or remarkably reduced in these patients. Now coming towards the urinary albumin excretion rate, and it is considered that the normoalbumin urea is considered if it is less than 30 milligram per day, because there are basically TAM, Hirschfeld protein, and many other proteins which are nothing but these are the epithelial cells and their proteins. They are normally lost there. And if microalbumin urea we are going to label, it is between 30 and 300 milligram per day. But once it crosses, then we call it overt nephropathy. And if it is persistently so, that is more than 300 milligram per day, and these are detected twice in a span of 3 to 6 months, then it is called persistent albumin urea. So now coming towards some other variations which we must also consider. One is the strenuous exercise, because this exercise, it sometimes gives albumin urea. So that could be a false perception in that case. Similarly, oral protein intake, if it is enormously increased, that also gives slightly more loss of proteins. And similarly, if there is a renal infection, that is UTI, our patient has got stones in the kidney, stone in the ureter, stone in the urinary bladder, or some other lesion might be responsible for hematuria. In that case, it is said that the fenestrations through which RBCs can pass, through which the WBC or pus cells can pass, a smaller molecule of albumin can definitely pass through. So if a patient's urinary examination reveals the presence of pus cells or presence of RBCs, then the albumin urea could give you a false impression of overpassage of a protein that has to be considered once we are going to interpret the albumin urea. Similarly, fluid overloading, that will also change the osmolarity and osmolality of the fluids, and ultimately that will also might be contributing towards the false impression. And in pregnancy, there is also changes, and we do expect that the things could be attributed to the pregnancy. Now, all these things have to be considered once we are going to interpret, once we are going to label, and once we are going to offer the intervention, that whether these things has been excluded before we are going to interpret the report. So this is what we have talked about, that type 1 yearly after 5 years. Yes, this is the follow-up. So once we find out that patient has got this microalbumin urea, I'm basically talking about the primary prevention. So we are searching towards the microalbumin urea patients, and now we are trying to prevent further progression, or I would say that we are trying to delay the catastrophe, which is basically sequelae of the natural course of illness, if the things are not naturally actually controlled, monitored, and calibrated at that time regarding the medication. So at that moment, one might be able to find that your patient is type 1 diabetic, and once you find out the microalbumin urea, then your follow-up should be at least 5 yearly, or in case of type 2 diabetes, then it should be annual examination and follow-up of the patient regarding this albumin. This is extremely important. Then coming towards the definition and problem, partly definition we have talked about, and we should also consider that if we are not going to tackle our patient nicely, if we are not going to offer intervention in the form of medication or whatsoever the preventive methodology could be adopted by the patient after its understanding, and the control of hypertension and meticulously controlling the diabetes mellitus, then definitely we should expect that patient might be heading almost 40% of the patient, they are going towards the end stage renal disease. And similarly, we should also consider that these patients, they have got strong association, which is 20 to 40-fold higher by the involvement of the cardiovascular system. So all these patients who are suffering from this nephropathy and hypertension, they are likely to develop cardiovascular sequelae or the bad events, which is 20 to 40 folds higher compared with the population who does not have got this complication. So all these things are basically the warning signs, and we must prepare ourselves as a healthcare professional that we have to prevent our patient who are basically heading towards the end stage renal disease, and also the concomitant involvement of the cardiovascular system, leading toward ischemic heart disease or frank involvement of the heart. So all these things have to be prevented accordingly. Similarly, there are stages I have talked about. There is hyperfiltration, stage of clinical latency, then incipient nephropathy, overt nephropathy, or renal failure. These 5 things, this is called basically Morganson staging. This is very important for any health care professional, that one may be sometime misled because initially the kidney sizes apparently appears normal, and similarly you might not have got frank albumin urea, and we are not going to quit these patients. We have to be vigilant enough that these are the various stages which must be kept in mind, and in these stages we have to detect the microalbumin urea. If it is not persistent, it's okay, but we have to find out ultimately by our close monitoring. So once we find out these stages, then definitely we have to offer the care accordingly to those persons. Now, in case of stage 1, hyperfiltration means that there is increase in the glomerular filtration rate. If you see the graph, then you will find out that if, for example, there is a horizontal graph going like this. So in the stage 1, GFR will go high, and then it comes into the second stage, and then going towards the third stage, and then it start declining to the extent that GFR could be remarkably reduced in this patient. So hyper 1 stage is there. Usually blood pressure is normal in these patients until unless the patient, they are known hypertensive previously. That is something else. Otherwise, if a patient is normotensive initially, patient has got this problem, diabetes mellitus and involving the kidneys, then definitely we have to rule out that your patient could have got this hyperfiltration state in which the GFR is raised. Then the glomeruli, they begin to show damage in case of stage 2, and there is microalbumin. In case of stage 3, albumin excretion rate exceeds 200 microgram per minute, and blood levels of the creatinine and urea nitrogen, they also start rising, and blood pressure also start rising in these patients. Stage 4, GFR is decreased to the extent that it could be even up to 75 milliliter per minute. We have talked about roughly the sketch 100, 75, 50, 25, I already talked about, and then 12.5 and 6 and 3 like this. So these patients have got almost this 2 creatinine, and large amount of protein actually passes through the urine. There is a rise of blood pressure, and levels of creatinine urea I have talked about, they also start rising. 5 stage is a stage of ESRD, that is azotemia. We should not expect that kidney is functioning now. They basically, these patients, they have got this kidney failure to such an extent that there is end stage renal disease. It means that the GFR is actually less than 10 milliliter per minute, and the average length of time to progress from stage 1 to stage 4 kidney disease is 17 years. Or a person with type 1 diabetes, the average length of time to progress to stage 5 kidney failure is 23 years in case of that. So these has to be considered accordingly. So these are various other graphical representation which starts with the normo-albumin urea and heading and passing through various stages and heading towards ESRD, end stage renal disease. Now please see the difference in the chronology. Initially, this took about 15 to 20 years in which there is macroalbumin urea. But once it's there, then it only takes 4 to 5 years to develop azotemia and ESRD for one in a year. It means that time is extraordinarily very, very important. Initially, 15 to 20 years for the prevention, for the controlling, monitoring, calibrating, and ultimately making a great degree of this professional contact with that patient, with the direction and the follow-up of the patient is extraordinarily important. And for this reason, the counseling of the patient, giving the patient awareness, and the evidence-based medicine should also be practiced accordingly, so that your patient should follow the directions, how to manage diabetes mellitus, and how the things have to be avoided, which actually increases and potentiates the damage that has to be avoided. And similarly, once there is a nephropathy, then hypertension is more dangerous than the abnormal glucose level. Hypertension itself is a sequelae of this diabetic nephropathy, but once it's developed, its control is extraordinarily more important than the meticulous control of the this hyperglycemia. So now the two things are very it's notorious in this way, that you have not only to visualize and this is calibrate the sugar level accordingly, but hypertension now overpowers the power of this hyperglycemia. You have to control it. So if we are not going to give a good management, then it takes only few years for the development, which is basically being a bit ahead in the form of end-stage renal disease. Now, this represent sort of changes which might be anticipated on one side, and on the other side is type 2 diabetes mellitus, in which the patient could be having microalbuminuria at the time of diagnosis. Or I would say, just heading another arrow, that is white arrow, sometimes the patient might be presenting with macroalbuminuria. Very few patients which are diagnosed for the first time in life in type 2 diabetes mellitus. Because type 2 diabetic patients, they usually present with some sort of complications. And very rarely, patient might be presenting with renal failure and then they are known to have diabetes mellitus type 2. So these are one very unlucky patient who may not be passing through all these stages in the presence of a doctor, in the presence of a clinical healthcare professional. But they might be coming with the complication, which might be almost the end-stage renal disease, and one might not be aware of that he is suffering from this diabetes mellitus. So this is extremely important. These are few electron microscopic pictures which depicts the changes which occur at the pathogenic level in these patients. So there are three main things which could occur in these patients. Number one, the earliest changes, the thickening of the glomerular basement membrane. That is early thickening. And then comes another change, which is basically the mesangial proliferation. Mesangium are the matrix which is present just by the side of all these cells. So that might be proliferating in these cases. And this is due to certain factors which are affecting them. Sometimes it is a tumor necrosis factor. Sometimes the growth factor, they are responsible. Then deposition of collagen is also there. And sometimes endothelium proliferation factor, which are not only contributes over it, but also contributes in various capillaries of the kidneys as well. And third thing is the glomerulosclerosis that could also be present. So these three things make the changes inside the glomeruli, inside the kidney, inside the nephrons, and then ultimately is responsible for this initial microalbuminuria, and later on frank albuminuria could also be started. And among those, the typical lesions are this chimal steel Wilson, these lesions, which are basically nodules, which are visible in the electron microscopic picture. And this has got this glomerulosclerosis as well. So these are various stages through which the patient is passing, and the kidneys they are passing. These various things they form the first stage, second, third. These chimal steel Wilson lesions, these are present in the third stage, and in the fourth stage they are quite normal. So even a single lesion, if it's there in the third stage, then histopathologically this is a classical picture of what we call as chimal steel Wilson syndrome. Now this is the associated phenomena which could occur in these patients who are suffering from this hypertensive nephropathy. So ultimately diabetic nephropathy, hypertensive nephropathy, and similarly all these catastrophes which are aligned, which are associated in that particular patient. मैं तो हमेशा ये मिसाल देता हूँ कि जैसे एक गाड़ी है, उस गाड़ी का स्टीयरिंग खराब हुआ, एक्सल खराब हुआ, गियर खराब हो गया, और उसके बाद पता चला ये जनाब आपके हाथों से निकलती जा रही है. तो इस तरह की गाड़ी बनती जा रही है जो इनिशियली तो एक ही प्रॉब्लम था, लेकिन अल्टीमेटली दूसरे सारे उसके साथ प्रॉब्लम पैदा होते चले गए. तो अगर हम किसी एक स्टेज को नहीं रोक पाते, तो इट मीन्स दैट वी आर बेसिकली अलाउंग द तो उस गाड़ी को अगर हम शुरू में ठीक नहीं करते, उसका एक्सल सही नहीं है, तो अल्टीमेटली स्टीयरिंग भी गड़बड़ हो जाएगा, और अगर उसका साथ में गियर भी खराब हो गया तो कैसी गाड़ी चलेगी, तो रोड पे तो नहीं रहेगी. So similarly, these patients may develop myocardial infarction, heart failure, stroke, and sometimes even sudden death. So it means that we have to be vigilant enough. So once we are going to take up the patient as a whole, after taking the history, clinical examination, we shouldn't forget that there are always some modifiable and non-modifiable factors responsible. Now, considering the modifiable factor, it appears to be more practical for every health professional. He thinks that probably he is going to intervene to correct them or at least to stop them. But regarding this non-modifiable factors, one can't do anything. But it is important to know what are the non-modifiable factors in this patient, because if you know them, you can predict the prognosis in those patients. Now, how vigilant you have to be. So in these things, there are various steps. I am not going to go into the details because there are minor details in that. So race is important, genetic influence is important, low birth weight is important, age of onset of diabetes mellitus, this is important, kitni lambi arse mein wo diabetes rahi hai, this is important, and similarly elevated prorenin level, which is one of the contributing factors. So these are non-modifiable factor, लेकिन इनको हमने कैटेगराइज करना है 1 2 3 4 5, इसी से हमने स्ट्रेटिफिकेशन करनी है, and by which we are going to make a sort of plan accordingly, and how vigilant we have to be regarding the implication of these interventions. Now, these are modifiable factors which we have to consider in those patients who are suffering from this diabetic nephropathy. One is hypertension. The second one is dyslipidemia. Then is smoking. Then is the poor glycemic control, obesity, oral contraceptives, and increased protein intake. These are various modifiable factors which you can correct, which definitely a very good health professional can outline 1 2 3 4 5, and that has to be outlined at the time of first visit. जो ही आपके पास पहली दफा मरीज आता है, तो डोंट कंसीडर कि मैंने तो इसकी जनाब शुगर ठीक कर रही है, दैट्स ऑल. नो, हमने उस पर्सपेक्टिव को देखना है. तो बाय दैट we basically offer a sort of tailor-made type of prescription, because every patient is a different patient, makeup different है, उस patient की lifestyle, eating habits, ये सारी चीजें different है, उसका occupation different है, उसकी timing खाने की different है, उसकी salt intake का different criteria चल रहा है, उसके cultural और उसके norms different है. तो ये सारी चीजें हमने इसको देख के, उसकी sleeping habits को देख के, ये सारी चीजें, उसका hydration status कहता है, पानी कैसा पीता है, कब पीता है, तो ये सारी चीजें देखने के बाद हम फैसला करेंगे. और फिर उसका बायोकेमिकल करा के हम देखेंगे कि उसका HDL कैसा है, ऑलरेडी 35 ईयर्स से लेस तो नहीं है, और ट्राइग्लिसराइड लेवल कैसा है उसका, मोर देन 150, और थिंक डायबिटीज और हाइपोथायराइडिज्म विद द अबव लिपिड प्रोफाइल, because the mixed edema, that is the decreased level of thyroxine in the body, that also contributes towards the this hyperlipidemia, hypercholesterolemia. And there are some patients who are suffering from this primary hypercholesterolemia. So all these things have to be considered accordingly. And similarly, we have to definitely go for the TSH, thyroid stimulating hormone. That will give us, अगर वो बहुत ज़्यादा है, आप किसी का TSH यानी वो 50 और 100 पे पहुंचा हुआ है, तो वो तो frank case of eczema का. We do expect that all these patients, they have got this type of this contributing towards the deleterious effects and the bad consequences of the patient, which could head towards various other complications as well. तो ये सारी चीजों को हमने consider करना है, and definitely we are able to make a sort of list. Now, it's important that we must be able to see what kind of different interventions can be done at different stages. So these are the predictors of this progression. तो अगर आपका पेशेंट जो है वो नॉर्मो एल्ब्यूमिन यूरिक पेशेंट है, तो हमने ग्लाइसेमिक कंट्रोल रखना है, बिकॉज दीज पेशेंट यूजुअली हैव गॉट नॉर्मल ब्लड प्रेशर. तो आपने ज्यादा कॉन्सेंट्रेट इसके ग्लाइसेमिक कंट्रोल के ऊपर रखना है, और जो बैकग्राउंड में हमने चीजें डिस्कस कर दी हैं, those are lipid profiles, cholesterol, TSH, and then eating habits and all these things वो आपने accordingly manage कर दी. Now अगर ये establish हो चुकी है diabetic nephropathy, then definitely hypertension, जो मैंने अभी थोड़ी देर पहले बात की है, कि not only the meticulous control of diabetes, but the hypertension has to be considered as it's one of your primary responsibility as well. And then degree of protein urea has to be taken into account. And if the patient has fast another stage, then renal biopsy. That will give us how much mesangial expansion has occurred and what is the status of tubulo-interstitial lesions. That will give you the idea that what kind of other renal replacement therapy, which I'm going to discuss afterwards. So that has to be considered in those patients accordingly. Now, I have talked much about this hyperglycemia, then is hypertension and proteinuria. Accordingly, ये सारी चीजें इसको हमने manage करना है accordingly. Now, hurriedly I'm going towards the treatment because now there is established this figure of that particular patient. Its biochemical status is there. If renal biopsy is done, that's also with you. So all these things. Now we are going to generalize certain outlines, certain guidelines for our patients. हमारे पास एक पेशेंट है जो डायबिटिक है, वो किसी भी स्टेज पे आ सकता है, तो उनमें से हमने किस तरीके से किन चीजों को कैसे मैनेज करना, तो उसमें प्राइमरी रिस्पॉन्सिबिलिटी हमारी ये है, बिकॉज द प्राइमरी डिजीज इज डायबिटीज मेलाइटिस. नाउ डिपेंडिंग अपॉन वेदर इट इज टाइप 1 और टाइप 2 और व्हाटसएवर द स्टेज ऑफ द पेशेंट इज, अकॉर्डिंगली हमने उसको वो तमाम चीजें ऑफर करनी है which can actually bring a very good monitored control of diabetes mellitus apart from everything else. So first of all, we are going to consider the non-pharmacological maneuvers. जब भी कोई मरीज हमारे पास आएगा, pharmacological maneuver से पहले उसको ये चीजें सिखानी, because one is not known about all these facts. What are the non-pharmacological maneuvers which could actually help the patient to control the diabetes mellitus? Then he will never know for the whole of their life कि किस तरह कंट्रोल करना है. जैसे एक मरीज आपके पास आया, उसकी शुगर 250 है, उसको किसी गोली पे डाल देते हैं, तो उसको जिंदगी भर समझ नहीं आएगा, क्योंकि उसकी डायबिटीज कंट्रोल हो जाएगी. उसको पता ही नहीं चलेगा कि मैं कौन सी चीजें खाऊं, कौन सी ना खाऊं, कितनी खाऊं, किस मिकदार में खाऊं, कितनी एक्टिविटी करूं, सोना कितना है, जागना कितना है, और पोर्शंस ऑफ डाइट को कैसे बनाना है अपने, और इसकी जो मुख्तलिफ स्टेजेस है, सुबह का खाना है, फिर उसके बाद MMR, फिर उसके बाद लंच है, फिर उसके बाद मिड आफ्टरनून मील है, फिर उसके बाद डिनर है, सफर है, ये सारी स्टेजेस को गुजार के फिर उसको बताना है और कैलोरी वैल्यू समझानी है. तो ये इनिशियल हमारे पेशेंट की एक एजुकेशन. उसके साथ हमने ग्लाइसेमिक कंट्रोल के साथ ड्रग्स कौन सी देनी है वो हमने फैसला करना है पेशेंट का अकॉर्डिंगली, और बैकग्राउंड स्टेटस देखते हुए, क्लिनिकल स्टेटस देखते हुए, बायोकेमिकल स्टेटस देखते हुए, और देखना है कि ये इंसुलिन वाला केस है, ये गोलियों से ठीक होगा अकॉर्डिंग, या इसको कॉम्बिनेशन थेरेपी देंगे. आफ्टरवर्ड्स इज द ब्लड प्रेशर कंट्रोल एंड मॉनिटरिंग. आई हैव टोल्ड यू कि एक स्टेज गुजरने के बाद जो ही ब्लड प्रेशर हाई होता है, तो फिर हमने कौन सी दवाई देनी है, कितनी मिकदार में, ये फैसला करना, और फिर हमने देखना है कि इसकी एंजियोटेंसिन को कंट्रोल कैसे करना है, और प्रोटीन यूरिया का कंट्रोल, और फिर कोलेस्ट्रॉल, ये एसोसिएटेड चीजें हैं. अच्छा, उसके बाद एक चीज और मैं आपको हाईलाइट करना चाहूंगा, that is basically anemia. Anemia also contribute towards the worsening of the renal function. वो हम उस पर बात करेंगे, जिस तरह हमने बात की थी लिपिड प्रोफाइल की, कोलेस्ट्रॉल की, ब्लड प्रेशर की, डायबिटीज की. तो that is also one of the contributing factor जिसको लोग कंसिडर नहीं करते, because this ischemia can also actually affect the renin-angiotensin system as well, because juxtaglomerular apparatus is basically stimulated by ischemia. तो अगर एक पेशेंट में ऑक्सीजन कैरिंग कैपेसिटी कम है, तो दैट में आल्सो कंट्रीब्यूट टू सम एक्सटेंट. सो अनीमिया को हमने माफी नहीं देनी, उसका भी हमने कंट्रोल अकॉर्डिंगली करना. नाउ कमिंग टुवर्ड्स द इंसुलिन, आई एम नॉट गोइंग टू गो इनटू द डिटेल्स. देयर आर मल्टीपल इंसुलिन अवेलेबल इन द मार्केट. रेगुलर है, इंसुलिन एस्पार्ट है, और फिर बेसल इंसुलिन, ग्लार्जीन है. तो ये मुख्तलिफ रेजिमेंट्स हैं जो हमने अपने पेशेंट को ऑफर करनी है अकॉर्डिंगली. इनिशियली हमने रेगुलर इंसुलिन स्टार्ट करनी है, और उसके बाद उसकी मॉनिटरिंग करनी है फास्टिंग की 2 और पोस्टप्रेंडियल की, और 6 टाइम का हमने करना है सेल्फ मॉनिटरिंग ऑफ ब्लड ग्लूकोज, उसको सिखाना है. सिखाने के बाद हमने रेगुलर के बाद फिर लॉन्ग एक्टिंग, इंटरमीडिएट एक्टिंग, उसका कॉन्सेप्ट उसको देना है, और ग्लार्जीन का कॉन्सेप्ट देना है, बेसल और बोलस इंसुलिन का देना है, और अकॉर्डिंगली हमने एज ए प्रोफेशनल इनको बना के एक पूरी रजीम दे देनी है, और पेशेंट को इतना सिखा देना है दैट द पेशेंट ही हिमसेल्फ मस्ट बी एबल that after self monitoring of the blood glucose, he must be even able to change the units of insulin accordingly. और रात को, आधी रात को क्या करना है, और ये सारी चीजें उसको समझा के, और what are the signs of hypoglycemia, what are the signs of hyperglycemia, ये सारी चीजें उसको सिखानी है accordingly. ये उन पेशेंट्स के लिए जिनको हमने इंसुलिन पे डाला. Metformin is a very good drug that has to be started in those most of the patients. लेकिन अगर किसी का यूरिया क्रेटिनिन बढ़ चुका है और उन पेशेंट में नेफ्रोपैथी एस्टेब्लिश्ड है, तो sometimes it is usually not tolerated because in those patients it might lead to anorexia, diarrhea, और accordingly आपको डोज भी एडजस्ट करनी पड़ेगी in those patients in which GFR has to be considered accordingly. जिसकी अगर कम हो रही है GFR तो उसके हिसाब से हमें उसकी डोजेज को भी कम करना पड़ेगा. तो अकॉर्डिंगली ये है कि एस्टिमेटेड अगर हमारे पास GFR 30 to 59 तक आ जाती है तो 1 ग्राम पर डे से ज्यादा हम उसको मेटफॉर्मिन नहीं दे सकते, और बिकॉज इट मे लीड टू फेटल इलेक्ट्रिक एसिडोसिस. दैट्स इंपॉर्टेंट. So then comes towards the glitazones. In that case, again, one have to consider the nephropathy, urea, creatinine, or estimated GFR, and we calculate करके. According to that particular situation, we have to change the glitazones as well. These are very good drugs. Now, important thing is also one thing जो मैं non-pharmacological maneuver के अंदर लेके आया था, उसमें weight reduction. अब हमारे बहाने से हमारे पास सिचुएशन पैदा हो गई है. एक पेशेंट जिंदगी में हमारे पास पहली दफा आया, टाइप 2 डायबिटिक है, तो हमने देखा कि इसका वेट बहुत ज्यादा है. अब जैसे जैसे उसको हम समझाएंगे ईटिंग हैबिट्स और लाइफस्टाइल मॉडिफिकेशन, उसके साथ वेट रिडक्शन इज वेरी वेरी इंपॉर्टेंट, so that he must not be requiring much amount of these drugs. तो नॉन फार्माकोलॉजिकल मैनूवर्स के अंदर ये सारी चीजें करते करते, और इसी तरह मेटाबॉलिक सिंड्रोम से भी उसको बचाना है. अगर एक वेट हाई है, उस पेशेंट के अंदर लिपिड प्रोफाइल भी बुरा है, उस पेशेंट के अंदर हाइपरटेंशन भी है और बैकग्राउंड उसकी हिस्ट्री भी है, फैमिली हिस्ट्री भी है, तो चांसेस ये है कि वो पेशेंट he will be heading towards the consequences which are very worse in very short span of time. So important thing, ये वो मैसेज है जो हमें वर्ल्ड हाइपरटेंशन डे के हवाले से मैंने शुरू में भी जिक्र किया था. So the measurement of blood pressure is likely the clinical procedure of greatest importance that is performed in the sloppiest manner. So these are basically Kaplan has also written one of the book very popular on hypertension, and he is authority in hypertension, I would say. तो उसने बड़ी खूबसूरत बात लिखी है कि ये स्लॉपीएस्ट वे के अंदर ब्लड प्रेशर लिया जाता है. कोई परवाह नहीं है कि इसका जो साइज है वो कैसा है. हमारे कफ का छोटे के साथ बड़े का ले रहे हैं, बड़े के साथ छोटे का ले रहे हैं, तो स्टैंडर्ड साइज को यूज नहीं कर रहे. तो उसके बाद यहाँ पे हमारे क्यूबिटल फोसा के ऊपर चढ़ा के कफ को रखा हुआ है. फिर उसके बाद तेजी से इन्फ्लेट करते हैं, तेजी से डिफ्लेट करते हैं. दूसरे एब्सोल्युटली रबिश. एक मरीज भागा आ रहा है सीढ़ियां
I think we have a slight disconnection at Professor Muniaz's end. Sir, meanwhile, I think I will request the panelists. We do have 2 questions. Actually, we do have a couple of questions. I'd like you all to answer, please. If the patient, diabetic patient, has hypertension and she is taking antihypertensive, but now her blood pressure is normal, is there any need of taking medicine now? Professor Tariq, please, and Professor Feroz, I'd like to request you all to answer, please.
So, since Professor Feroz had raised the hand, so I think he was going to answer first.
Okay.
Thank you, Dr. Wafa. Thank you, Dr. Tariq. Nice seeing you after a long time. Basically, the important thing is the medicine has to go on. There's nothing like dawai khatam ho gayi, bimari khatam ho gayi. Bimari is controlled. So what we need is to continuity of the controlled blood pressure. So the treatment has to be continued. Only if there are certain things like extreme factor like MI, heart failure, drop hua hai, so we can reduce the dose. But even now, in all the scenarios, the treatment of blood pressure will be carried on for the rest of your life. And last thing would be when you take your last breath, the treatment will go off. But the treatment can be hampered upon, they can be increased or decreased. But if it is normal, it's very good, means your compliance is good and your doctor is excellent.
Right.
In
Great.
fact, it may be added on that given the benefits of
Hello.
antihypertensive, do we have?
Hello.
Ji,
Okay,
sir.
Munir is with us. I think we can
Yeah.
go back to Munir
Okay.
and then we
Yeah.
can discuss. Okay.
Resume our
Munir?
discussion. Yes.
No.
I think, yeah,
So,
I think
but
just that,
I was telling that
yeah.
since protein urea, albumin urea is the hallmark of the diabetic nephropathy and all that, and sometimes there are some authorities who may even near normal or slightly normal blood pressure to reduce proteinuria may advocate use of continuation of particularly the ACE inhibitors. I can take again we can have opinion from Dr. Feroz as well. Do you suggest or do you recommend that diabetic nephropathy, early incipient nephropathy with just at stage of albumin urea or gross proteinuria should be started on ACE inhibitors, irrespective of whether their blood pressure is raised or not? Dr. Feroz, would you be?
I think we've got enough data now to suggest that the RAS inhibitors, that's ARBs or S inhibitors, are the backbone of treating blood pressure. Even if you've got proteinuria or if you've got renal failure, you continue them unless you're monitoring your creatinine. If it goes over the required limit like 5, then you might hold on and decrease the dose. Otherwise, ARBs and S inhibitors are to be continued in treatment of hypertension, whether
I think
renal failure.
Thank you.
Munir,
Thank you.
you are. I think you
Yes,
are
I
on
think
again.
Ji,
can
I think
resume.
he
Yes,
is.
yes.
Yes, sir.
Yes.
Please, you may take over now. Thank you.
Okay. But I lost the opportunity to listen to worthy Professor Dr. Feroz Mehman.
Yeah.
Yes. So this is basically sort of algorithm which I'm going to highlight at the moment. Evolution of protective benefits. If we are going to take the consideration of various things we have talked about, like ACE inhibitors, ARBs, calcium channel antagonists, beta blockers, alpha blockers, and their combinations, whatsoever it is, the ultimate goal is that we have to bring the blood pressure in a normal range. Now, what benefits we are going to get out of it? We can reduce remarkably the chances of getting stroke in future, heart failure, renal dysfunction, glycemic control, and of course CHD. So these are various things which we can basically get benefit out of it. Sorry. This is renin inhibitor. This was again one drug which was tried in one of the this study that is called as altitude study. So LS-Karen was one of the drug, but later on it was found out that there was no added benefit. I just brought into your notice that that was one of the drug which was used. So this is again algorithm I have talked about. Yes, this slide is important. If we are going to tackle a patient who is suffering from this diabetic nephropathy, then restriction of protein is extraordinarily important, and studies they reveal that if we consider that our patient is not going to take protein more than 0.8 gram per day and later on 0.5 gram per day, then these patients, they usually don't get worse with the passage of time. So protein intake is extraordinarily very important. That has to be considered accordingly. Anemia I have talked about, and I have told you the reason why we have to correct the anemia. So once you find out your patient with anemia, these patients usually have got decreased level of erythropoietin on one side, but once find out the anemia, then just not take it considered as he is suffering from iron deficiency. No, we have to go for the peripheral morphology. we have to consider whether it is normochromic normocytic anemia, hypochromic microcytic anemia, or macrocytosis, or it is a combination of all these things. And sometimes in case of additional this stage of this nephropathy, patient may have got normochromic normocytic anemia of chronic disease. So you have to consider the serum iron, TIBC, ferritin level, folic acid, vitamin B12 in the perspective of this peripheral morphology. So whatsoever the things they come down, accordingly we have to manage our patient. And very few patients, if they have got a very low level of this hemoglobin, then PEG cell replacement can also be one of the contributing factors to revive the hemoglobin level sometimes. But erythropoietin has to be given in combination to all these patients. But if they develop this 10 gram per deciliter hemoglobin, then usually erythropoietin is not needed, because this may sometimes lead to hypercoagulable state, and there could be patients suffering from TIAs, patients suffering from the stroke and various other PADs. So these are various parameters which have to be followed accordingly. I have talked about यानी ब्लड प्रेशर कंट्रोल हमारा टारगेट होना चाहिए लेस देन 120/80, और फिर उसके बाद ये है कि वी हैव टू कंसीडर AC inhibitors or ARB to the maximum level. Then HbA1c has to be brought down less than 6.5, or up to 7 is okay, but ideally 6.5. But always consider that your patient is likely to develop hypoglycemia with insulins, because the excretion of insulin and metabolization of insulin is usually delayed in these patients. So one must be warned always that he is likely to develop hypoglycemia late night. So one must be always vigilant. तो ऐसा नहीं है कि हमने 6.5 ग्राम जो है हमने HbA1c पे हर हाल में लेके आना है. आपने ये राउंड दी क्लॉक कंसिडरेशन भी रखनी है, और फ्रीक्वेंट सेल्फ मॉनिटरिंग ऑफ ऑक्सीजन, सेल्फ मॉनिटरिंग ऑफ दिस ग्लूकोज, और फिर उसका चार्ट बनवाना है मरीज से, so that you must be able to revisit once your patient come in front of you. Then hemoglobin हमने रखना है between 11 and 12, but it's okay up to 10 is okay. Aspirin daily देनी है, and smoking cessation is also important because this also contributes towards hypertension. So conclusion is that diabetic nephropathy is the most common cause of ESRD in the world. ये ज़हन में रखें कि ESRD की commonest ये सवाल अगर पूछा जाए तो diabetic nephropathies, and ESRD is not a rare outcome among diabetics, and over half of diabetics will develop nephropathy, almost 50% of the patients. This is extraordinarily important, and these are the interventions which could be done in this patient. The key message is that screening for diabetic renal disease is easy and should be performed annually, and good glycemic control is the main primary prevention therapy. Once microalbumin urea confirmed, RAS blockade is must, जो मैं पहले बात कर चुका हूँ, यानी AC inhibitor और ARBs, and आपसे बात की sometime उसमें आपको कैल्शियम चैनल एंटागोनिस्ट देने पड़ेंगे, बीटा ब्लॉकर देने पड़ेंगे, अल्फा ब्लॉकर देने पड़ेंगे, और डायूरेटिक देने पड़ेंगे. A treatment aims to stabilize estimated GFR and maintain urinary albumin excretion rate. Attention to all vascular risk factor is vital. और आखिरी बात बड़ी important है, if renal replacement therapy become necessary, this needs to be carefully planned well in advance. यानी अगर किसी का आप देखते हैं कि ESRD हो चुका है और इसका जो GFR है वो 10 से कम हो चुका है, तो आप वक्ती उसका फिस्टुला बना लें फॉर हीमोडायलिसिस. और अगर आपका पेशेंट अफोर्ड कर सके, आप ये समझते हैं कि ये पेरिटोनियल डायलिसिस का कैंडिडेट है, तो फिर CAPD वगैरह के लिए आप उसकी तरफ गौर कर सकते हैं. बट द आइडियल थिंग इज द रीनल ट्रांसप्लांटेशन. अल्टीमेटली आपने उस तरफ जाना है, तो ऐसे केस में अगर आप अर्लियर प्लान कर लेते हैं तो दैट इज एक्स्ट्राऑर्डिनरी वेरी इंपॉर्टेंट. एंड thank you very much that after renal transplantation my subject is finished, because this is what are the bad, or I would say worst consequences if a patient and the doctor they are unable to intervene the complication of diabetic nephropathy, controlling of blood pressure, controlling of lipidemias, hyperlipidemia, dyslipidemia, cholesterolemia, smoking, drug intake, and drugs which are going to be hazardous for the precipitation of renal failure. जैसे एक मरीज है वो नॉन स्टीरॉयडल एंटी इंफ्लेमेटरी लेने पे जिद कर रहा है और लिए जा रहा है, एक पेशेंट अमाइनोग्लाइकोसाइड की सूरत में ले लेता है. So there are many things which could actually worsen the patient. So all had to be considered. Thank you very much. I'm sorry for this intervention which occurred sometimes,
No, sir, of
but
course.
hopefully I conveyed the message.
Yeah. Thank you very much. Thank you very much, sir. I believe it would be criminal to not mention diabetes whenever we discuss hypertension, and it was a great lecture. Thank you for illuminating the importance of achieving target blood pressure and blood sugar levels in patients who already have renal compromise. We have been very glad to have been a part of it. Sir, we do have, I'll just take one question. What is the ideal screening test for microalbumin urea? If somebody has asked that question.
जी.
Ji.
Microalbumin urea, basically dipstick test that is available and that is accessible for the patient as well.
Okay. And how to define and diagnose hyperfiltration, which is the first stage of the renal compromise?
In that case, basically the GFR is increased, urine output is more, and if you ask the patient to go for ultrasonography, then the kidneys, they are also swollen. But usually these patients, they are normotensive, and all the patients, they basically attribute this urine output towards the uncontrolled diabetes mellitus. This is not the situation. If your patient has got a normal range of HbA1c and fasting as well as postprandial glucose level is okay, UTI is excluded, then chances are that simple urinary output is actually the first stage of hyperinfiltration.
Thank you. Oh, thank you, sir. I hope that answers the questions from the audience. We do have a couple of more questions, but before we take those, I will request Professor Feroz Memon, sir, please, for your valuable remarks.
Thank you very much, Professor Munir. It was an excellent talk, very nicely said. And as I said, that what we are talking today, the two target hidden enemies, we call terrorists within us. I mean, both are silent killers, both creep in silently, and both create really fatal complications and target organ damage. So your lecture was very good, very elaborate. One thing which I really liked was the measurement of blood pressure. I think nowadays what we are talking of is that this spirometer and barometer, these are obviously recommending digital measurements. So with digital measurements, you have to be absolutely sure how you are checking your blood pressure in a cool, calm, well-sitting position with an arm, chair, relax, and then check. Usually people take when they are upset, when they are aggressive, and then pain, they check and then they rush to a doctor, के blood pressure 180 हो गया और by 60 हो गया, क्या हो गया. So I think this is very important that our junior faculty, even we ourselves, should know how and when to take blood pressure, give patient a little rest time before we jump on taking your blood pressure, telling them that you are hypertensive. That part of the slide, I liked it very much. I think this is very important for the information of our youngsters. Thank you very much for the great talk.
Sir, thank you. Thank you very much for your valuable comments. As we head towards the end of the session, I will be requesting Professor Tariq Wasim. He's the Senior Vice President of PSIM. Sir, I will be requesting you to conclude the ceremony. However, I think we have time, another maybe 2 minutes to take perhaps one more question. Okay. Somebody has asked that if patient comes to us with hypertensive urgency, would we like to start treatment for life? That is the question.
I think Dr. Fawad made it clear that when you have examined the patient and you have found an already existing target organ damage or evidence of that, and if your first encounter with that, and you have all that evidence, then of course there would be need to start. But again, the thing was pseudo emergency and emergency and pseudo hypertension versus that. So if we have clarified after the examination, some lab tests and that there is some evidence of target organ damage already there, right? Or there are comorbidities, then I think we will send him with a prescription of antihypertensive to be taken. But if it is not there, then the standard protocol is that re-examine him depending upon the number, maybe after a week, after a month, or after 6 months. There is a clear-cut guideline given about that how frequently or how this patient needs to be examined. That would be my answer for that.
Right. Thank you, sir. Sir,
Now,
another question for Professor Feroz. How to treat malignant high blood pressure? That would be our last question, and we'll go back to the conclusion then.
That is a good question. I think Fawad also wrote on that. Malignant hypertension, first we have to make sure if it is primary, secondary, you look at the cause, and then when we talk of treating blood pressure, we have to give in all the 4 classes of drugs and to control it. But I'm sure that if there is malignant blood pressure, there must be a cause starting from pregnancy to any important secondary cause. We have to look at that cause and then treat accordingly the figure of the patient and the concomitant morbidities and the factors the patient has got.
Right. Thank you very
much.
Of
course, this would definitely, as Babad mentioned, this would come into category of a hypertensive emergency, right? And
absolutely.
for emergency, of course, then we have to, because the vision is at stake, right? He has dwelling papilledema, he's at risk of developing blindness. So there you probably have to intervene in the form of all those available injectable, or as Dr. Feroz mentioned, maybe multiple antihypertensives simultaneously. And of course, drugs like nitroprusside or labetalol or these would be required there.
Right. Right. Thank you. Thank you very much, sir. Professor Tariq, sir, you'll take over for concluding remarks.
I think we had a very wonderful 2-hour session, and the first session has already been summed up and probably concluded as well. And I have just one or two things to be mentioned regarding. I think while Munir was presenting, I can call him Munir because he's my class fellow, right? So when we were presenting, so we missed a little part of management component. That which the first thing is that we already mentioned 50% of the diabetic are hypertensive already when we start them examining, and rest of them 50 would become in next 15 to 20 years of course of their diabetes. The agent of selection and at which agent at what stage of diabetic nephropathy and diabetes itself, right? So I think we would have to have some comment about, my other colleague panelists may also join, the role of thiazides. There with the potential risk of some hyperglycemia, with potential some risk of hyperuricemia, and particularly this becomes important in renal failure patient, that uric acid again is one component which also has to be dealt with. So that we would like to have a comment from both the, I'm not concluding, but I'm initiating discussion again, right? So that's in SGLT2 inhibitors, because when you're talking of, since we have to manage both, and this increasing role of this SGLT2 from heart failure perspective as well as renal failure perspective, because once renal failure sets in, the choice of oral hypoglycemic gets limited down to very few agents. You can't go with the glimepiride, you can't go with metformin. Munir already mentioned that. And then this new drug SGLT2, both for glycemic control, for heart failure, Feroz Memon can add to it. It is the empagliflozin, the study that probably something which we have to highlight. And another thing was the mention of this GLP agonist, right? Because their role both at stage of renal failure as well as a comprehensive management of diabetes and bottom. So I may go back to the concerned specialist that maybe some comment about SGLT2 in this combo. We usually call this hypertension diabetes a crime in partner. Okay? So they are partner in crime. You said it's criminal, so I said they are both. So. Right. Feroz, would you like to have some comment on SGLT2, GLP, particularly from your cardiologist point of view and from maybe our internist and nephrologist all together?
हमने तो अब इतना encourage कर दिया है कि आपकी diabetic drugs have become cardiac drugs. So we have taken, not only we are using these drugs, but we are using it even if you are not diabetic, we are using SGL2 as well. And levofloxacin and these drugs are now really wonderful drugs, a wonderful advance in treatment of heart failure. And obviously, I think this is become a norm now to treat heart failure along with Arni and Avogadine. The thing about the talking of thiazide diuretics, when we were students 30, 40 years back, I mean, thiazide was the treatment of choice to begin with. And nowadays, after that, now since we've learned a lot of this hyperuricemia, hyperlipidemia, and diabetes, we are using thiazide as a little pinch of drug along with S inhibitors, ARBs, or beta blockers. So we're using just quite part of it. And it's still now, if you look at the guidelines, all these things, all that's recommended among the first 4 drugs, but we prefer to start with ARB, S inhibitors, add in amlodipine, then if required, we add thiazide. And as we all know, that malignant and uncontrolled hypertension cannot be labeled so until we add a diuretic in it. So I think thiazide becomes a little late in management, and that also in such a small dose, it's so effective that we can ask the diabetes and hyperuricemia to stay away if we are using it in a small dose. So we should not shy away from those drugs. And again, the thing is that in Hyderabad today, temperature is 44. And if we are recommending somebody to use diuretic in this temperature, he will have more of a dehydration rather than uncontrolled blood pressure. So you have to make sure हम उसको क्या दे रहे हैं.
Right.
So one thing I will, Tariq, you have rightly pointed out, because the things were very much elaborated and 2-3 things missed. Regarding the thiazides, it not only is responsible to raise the level of this uric acid, and especially it's a big issue in patients who are suffering from this nephropathy. The other important thing is that this enhances the desensitization of the receptors of insulin as well. So if we are going to use this thiazides, there is a double-edged effect on those patients who are suffering from this uncontrolled diabetes on one side, and similarly we are adding towards the uric acid level. And moreover, if the patients, they are also suffering from mixed edema, thyroxine
There's a problem, I think, connection problem.
Yeah, I think
level
we've
is also
lost,
important for uric acid. And those patients who are so, and if a patient has got some aligned or associated heart role, but again the estimated GFR is important. Whether we have to or not, because then 50 to furosemide, again furosemide has got again these 3 problems. So very rightly pointed out by Feroz Mehman Saab that it is only the pinch of this medication which is needed.
Thank you.
And definitely SGLT2, these things are extraordinarily important once a patient has got associated cardiac failure. So we can definitely get benefit out of it. But few of the patients who doesn't have got this heart failure, or that they don't have got edema in the body, then they always complain that they have to rise up at night for frequent urination. But those patients who are going to tolerate it, this is an extraordinarily very good drug and very good addition. Thank you.
One last comment which I would like to, that as we were talking in the first session, when not to give something, right? So when is the time to not to give ACE inhibitors, ARB? And again, what kind of monitoring we need to do when we are treating diabetic hypertensives? We have to monitor their potassium because ACE and all that and renal failure. So many a times we have seen some, I would say, malignant hyperkalemia occurring because of the checked use of these agents. So that's important. Similarly, there have been changing cutoff values for not to use ARBs because of those further adding the insult of acute renal failure. So usually, I still believe maybe my two other colleagues will second it, that with the creatinine of 3+ or 4+, you probably have to withdraw or stop or not to start ACE inhibitors in that very population. So they are very good when given from the GFR is maybe normal or up to maybe 50%, but below 50% GFR, if you are tend to start, you don't start with ACE inhibitors. And if you are already using it, you either have to cut it down or have to withdraw it. That's important. And third, again, the combination of this diuretics and all that. So when you are monitoring these patients, you have to monitor their uric acid. You have to monitor their, of course, glycemic control. You definitely do it. You have to monitor their potassium, and you have to monitor, of course, their urine output as well. Because the first principle we teach our students is do no harm. You are trying to benefit him, but you may be adding to the harm as well. And that's why that we also have to teach when not to use a drug. I also tell, it is very easy to say कि ये कर लो, ये कर लो, ये कर लो, लेकिन उसको ये बताना कि ये नहीं करना, ये नहीं करना जो है, ये भी बहुत important है. And this is part of teaching and training of our juniors and of course our family physicians, all friends, that they think. And many times Firoz would add to it, we stop ACE inhibitor and he goes to a family physician and कहता है ये क्यों बंद कर दी तुम्हारी उसने, blood pressure तुम्हारा यहाँ पहुंचा हुआ है, and then we have to difficult to explain it. So all in all, we had a very wonderful session. Thank you, Wafa, for very nicely moderating it. Thank you, my colleagues Firoz and Munir, for being part of more of a academic discussion. I think we enjoyed it. I don't know what about the rest of the audience as well. And thank you, Getz, for this arranging this all. And we had a very nice participation as well. I mean, having almost 300 plus attendance on both days. And we still have लोगों के क्लिनिक का टाइम शुरू होगा 1:15. अभी भी हमारे पास 7 मौजूद हैं. मेरे ख्याल है फिरोज ने भी क्लिनिक पे ही जाना ही होगा.
Thank you very much, Tariq, for honoring me to be on your platform of Society's platform.
We love to have you. We had a wonderful time recently in Hyderabad as well.
Moderated the session very well, mashallah, and thank you for kind introduction as well.
Thank you.
Tariq,
Thank you.
Forward to see you back in Hyderabad again.
Inshallah.
Thank you very much, sir. Thank you very much for this great academic discussion. I think as a community together, we need to make efforts to raise public awareness so that early diagnosis, accurate BP measurements with effective medication titration can be achieved, so that human life can be both the quantity can be increased and also the quality can be improved. I will thank our audience. You've been great. A big thank you to PSIM and Getz Pharma for organizing a great event. And I would like to thank all our participants for being here. And it was definitely during lunch hours. So thank you very much. And Allah Hafiz from us.
Allah Hafiz.
Allah Hafiz.
Allah Hafiz.
Allah Hafiz.
Sir. Thank you, sir. Thank you.
Thank you.
Hafiz.
Allah Hafiz.